have plenty of time. So we're so lucky today to have Dr. Courtney Sherman speak to us today about alcoholic liver disease. She's a transplant hepatologist, associate professor of medicine, transplant hepatology fellowship program director, and also the director of the alcohol-associated liver disease program and the HALT clinic, which stands for Healing Alcohol-Associated Liver Disease Together. She obviously has a particular interest in alcohol-associated liver disease, for which she conducts research and has this wonderful clinic. She earned her medical degree at New York Medical College and then completed a residency in internal medicine at UCSF, where she served as chief resident. She also completed fellowships in gastroenterology and transplant hepatology here at UCSF. She works closely with the UCSF Liver Transplant Outreach and Community Liaison Program to improve access to liver care for patients who live far distances from San Francisco. And if you are lucky enough to work with her on the LTU wards, she's a wonderful, kind, and patient teacher. We are so lucky to have you today. Thanks, Courtney.
Thank you, Zoe. Thank you all for having me, and thanks so much for the great intro. It is definitely a big topic and one that I am very excited to talk to you all about. So we'll just jump right in. Happy to answer any questions at the end. So just pop them into the chat and we'll go from there. Okay, so the first thing I want to do is make sure that we're using the right language. So before we really dive in, I want to make sure that we're kind of part of the solution in terms of reducing stigma. There's a lot of stigmatizing language in medicine, and we really need to make sure that we are kind of reducing stigma and making sure that we are supporting patients' dignity and their self-esteem. So instead of using terms like alcoholic, we should really be switching things over to alcohol use disorder instead of saying alcoholic liver disease or alcoholic cirrhosis, alcoholic hepatitis, kind of shifting everything over to alcohol associated. And then when we're thinking about when patients return to alcohol use, instead of using terms like recidivism, which has kind of a negative connotation, we should be thinking about saying, you know, return to use as opposed to recidivism. So I think that's a really important kind of small point that is important for us to be thinking about for documentation and how we, you know, talk to each other about people and how we talk to our patients. So with that out of the way, we'll just kind of dive right into our agenda for the next 54 minutes. We'll do a little epi, we'll talk about acute alcohol-associated hepatitis, diagnosis and management, and then we'll spend the latter half on liver transplant for alcohol-associated liver disease, including early liver transplant or ELT, which is transplant with no period of abstinence prior to transplant. So we're going to start by reviewing some of the nitty-gritty on alcohol use disorder and alcohol use in general. Full disclosure, I am not boarded in addiction medicine. I have some formal training, but very little in addiction medicine. So just take that with it. So over time, we're seeing increasing rates of alcohol use disorder. And this is an older study, but I think still very representative of what we're seeing. So this is data, and sorry, it's a little bit blurry, from two large nationally representative surveys of US adults that show that 12-month alcohol use and just heavy drinking, as well as alcohol use disorder in general, increased for the total US population, but particularly among subgroups, women, younger adults, racial and ethnic minorities, and socially economically disadvantaged people. So as a reminder, the National Institute on Alcohol Abuse and Alcoholism, or the NIAAA, has very specific definitions of drinking levels, and they are different for men and women. I think it's really important for us to know that so that we can better educate each other and our patients. So here are the drinking levels defined based on the NIAAA. And so you can see differences between men and women for moderate, heavy, and binge drinking. There's increasing evidence that says that minimal or even no health benefits to drinking at all, despite what has been previously told to us in the past, and that any amount of alcohol use actually has potential to cause harm. That said, it's estimated that only about 10 to 20% of people with chronic heavy alcohol use will develop cirrhosis. And it's really the amount and duration of alcohol use that are the primary risk factors for alcohol-associated liver disease. That said, there's a lot of individual variability related to genetics, comorbidities, particularly obesity, and if people have concomitant liver disease. I think another thing that's really important to do is just remember what a standard drink actually is. And so if you are asking your patients how much are they drinking, it's important to ask them, what one drink means to them, because one drink might not be like one shot. It might be a pint of vodka. So if you ask them a pint, it might be a pint of beer, it might be a pint of vodka. So just making sure that you're asking those questions to really get into the nitty gritty of how much they're drinking. People are always asking, what is the difference between beer, wine, or, I stopped drinking liquor and now I'm only drinking beer. So all types of alcohol increase the risk of liver disease, but there's maybe some limited data suggesting that there's a higher risk with liquor compared to beer or wine. But I still counsel folks that alcohol is alcohol, and that if they need to abstain, they need to abstain. So while we understand these drinking limits, how do we make a diagnosis of alcohol use disorder? The AGA recommends standardized and really universal screening practices for alcohol use disorder at every medical encounter, whether you're a primary care doctor or in the GI clinic, or seeing somebody on an admission for something completely unrelated. This is kind of the moment where you strike while the iron is hot, do some screening. This is an opportunity to employ some motivational interviewing strategies and really screen in a non-biased manner. So this is a very busy slide, and it is the DSM-5 diagnostic criteria for alcohol use disorder. It's quite cumbersome and takes quite a lot of time to go through each of these questions. So, I'm not asking you to do this at every single GI or primary care or, ER visit, but there are some great screening tools that we should use and are endorsed by our different GI and liver societies. So there are 3 common screening tools that don't diagnose an alcohol use disorder, but they help identify misuse and should really prompt us to evaluate people further. So the first one that I think is probably the easiest one for us to use is the alcohol use disorder identification test consumption. So that's Audit C, that you may be familiar with. It's only 3 questions, and it actually performs better than CAGE, which many of us are familiar with from prior training. CAGE, remember, is cut down. Have you ever asked if you have you ever tried to cut down? Have you felt annoyed? Do you ever feel guilty? Do you need an eye opener? CAGE is really not as well validated across ethnic groups compared to Audit C. And so again, Audit C is really kind of more favored. There's another one that is quick and easy, the single alcohol screening question that was developed by the NIAAA. And it's just, how many times in the last year have you had 4 drinks, 4 or more drinks for women, or 5 or more drinks for men in one day? It might surprise you that a positive response is just once or more, with a sensitivity of 73 to 83% and specificity of 74 to 100% for unhealthy alcohol use. So really kind of pick which one fits best for you. The Audit C is, I think, probably the easiest one, particularly because it's actually embedded in Epic in our speed buttons on the left-hand column at the bottom. The little martini glass at the bottom is actually the Audit C question. So it's easy to kind of go through that quickly. So in addition to seeing more and more alcohol use disorder, we're seeing increasing alcohol-associated liver disease rates. So we're seeing a pretty significant increase in prevalence since 2014, and the trajectory is really accelerating even more recently. As I kind of highlighted earlier, younger adults, women, racial and ethnic minorities are the groups with the largest increases in both AUD and ALD. There was a study recently that looked at NHANES National Inpatient Sample and the UNOS review that showed that young age, female gender, and Hispanic race were independently associated with ALD burden and acute on chronic liver failure in the US. So this is really kind of highlighting key populations for us to target for screening, prevention, and treatment. I think another thing that I really wanted to highlight is that you may be seeing more and more women, particularly younger women, in clinic, in the hospital, with alcohol-associated liver disease. And the reason for that is that women are more susceptible to liver disease with less alcohol consumption, and it's really narrowing the gender gap, but not in a way that we want. And this, we think, is related to smaller volume of distribution, reduced gastric alcohol dehydrogenase compared to men, and sex differences in alcohol metabolism. This was really highlighted in the pandemic. So this is a chart from a review from some community hospitals in Fresno by one of our UCSF Fresno partners, Marina Reutman. She compared, their group compared pre-COVID and COVID era admissions for acute alcohol-associated hepatitis. And they saw a significant increase in both women and younger age group, people less than 40, in terms of admissions for acute alcohol-associated hepatitis. I think that people who are working in the hospital over the last 5 years can say that that is certainly what you've been seeing. It's certainly what we've been seeing in the clinic and in the hospital. So in addition, not surprisingly, we're seeing increasing alcohol-associated liver disease mortality rates as well. So this is a bar graph of the annual average percent change for deaths due to alcohol-associated cirrhosis in the US. Overall, all increasing. And you'll notice that the most rapid increases are happening in Louisiana and California. So it's definitely important for us and a hot topic for us to be paying attention to. Again, not surprisingly, we're seeing more and more transplants for alcohol-associated liver disease, and ALD is the most common indication for transplant in the US. Since the COVID pandemic, alcohol, again, is the fastest increasing cause for liver transplant. So I wanted to show you this as kind of a graphic representation of this. So this was a study that looked at listing for liver transplant in the pre-COVID era versus in the COVID era. So if you look at the green versus the blue lines, the green line is alcohol-associated liver disease pre-COVID era, and the blue line is non-alcohol-associated liver disease pre-COVID era. And this is the incidence of getting a liver transplant. So you can already see that people who had ALD were getting listed and transplanted more often than people with non-ALD indications. However, if you look at the red line and the tan line, that is in the COVID era. And you can see that the red line, ALD, compared to the tan line, non-ALD, that disparity really widens in the COVID era. So we're having a significant increase in the patients with ALD who are getting transplanted compared to people with non-ALD indications. So now that we've gone through kind of the background, we're going to just jump right into acute alcohol-associated hepatitis, which is something that you're going to see definitely in consults in the hospital. This is a good opportunity for us to review the diagnosis and management. So alcohol-associated hepatitis, or AH, has really a broad spectrum of clinical presentations. They might just have non-specific constitutional symptoms to symptoms attributable to advanced liver failure. Interestingly enough, because of the inflammation and steatosis that you can see with ALK-HEP, you can actually get de novo portal hypertension in patients who have minimal pre-existing liver disease or who are previously compensated. So to help us guide clinical decision-making, study design in this population and clinical trials, there was this 2016 consensus statement on making the diagnosis of acute ALK-HEP that we are going to review. So there are some clinical diagnostic features, including the onset of jaundice within the last 8 weeks, ongoing consumption of over 40 grams for women, over 60 grams for men per day for 6 or more months with less than 60 days of absence before they develop jaundice, classic liver enzyme patterns, so AST greater than 50, AST-ALT ratio of greater than 1.5. Classically, we think about 2 to 1, but this kind of consensus statement and the NIAAA is also kind of saying that greater than 1.5 ratio would still fit the clinical diagnosis of ALK-HEP. Both AST and ALT should be less than 400. And I think that's a really important point because you're definitely going to get consults on patients who have transaminases that are really high, and people are going to ask you, is this ALK-HEP? And then obviously patients need to have jaundice. So there are also these potential confounding factors that we need to weigh when we're thinking about, does this patient have acute ALK-HEP? So some of these confounding factors might be ischemic hepatitis, like they're coming in with a severe GI bleed, sepsis, hypotension. Are they also using cocaine? Do they have a metabolic liver disease concomitantly, like Wilson's or alpha-1 antitrypsin? Could they have a possible drug-induced liver injury? Are they taking a new supplement or a new medication? I can't tell you how many times I have, by all the numbers and by all of what seems like ALK-HEP based on the data, patient says, nope, I don't drink. So uncertain alcohol use is obviously a confounding factor here. And if they have atypical lab tests, so if that AST to ALT ratio doesn't fit, if their transaminases are higher than 400, or if they have other serologies that are positive, like autoimmune serologies, ANA, smooth muscle antibody. We have to be thinking, like, could they have two things going on? Or is this even ALCAP? Is this something else? So knowing all of this stuff, how do we actually make the diagnosis? So this consensus guidance categorized patients into 3 different categories. Definite ALCAP, which is when we have the clinical diagnostic criteria and a histologic diagnosis. So these are people who have like clinical features perfect, and you get a biopsy. But it is very, very rare. I can count on one hand the number of times that I've biopsied somebody for possible ALCAP, because the clinical features really most of the time will give you the diagnosis. And that's where we find, that's what's called probable ALCAP. So that's clinically diagnosed, and they don't have potential confounding factors. And really, you can make that diagnosis just based on clinical features. Then the third category is possible ALCAP, where someone has clinical diagnosis, but they have potential confounding factors. So this is the category of patients who, are really saying, I don't drink, or they have autoimmune serologies that are positive, or there's something else going on that you're like, gosh, I'm just not sure if this is ALCAP. Those are the patients that you might consider doing a biopsy to confirm the presence of alcohol-associated steatohepatitis on a biopsy. So what does the diagnostic workup look like for ALCAP? First things first, you want to make sure that the clinical presentation really fits. So this is someone who is having prolonged heavy alcohol use, recent onset jaundice. They may have ascites. They may have fever and tender hepatomegaly. You also want to make sure that their labs fit those diagnostic criteria that I mentioned. Jaundice, AST to ALT ratio, often have coagulopathy, and you'll often see that people have a leukocytosis as well, but that is not necessarily a diagnostic criteria. Next, you're going to treat the alcohol use disorder and the liver-related complications. So we're not going to go into how you treat hepatic encephalopathy, but you're going to treat hepatic encephalopathy, look for precipitants, get them started on lactulose, plus minus rifaximin zinc. You have to really think about the fact that they're coming in with ALCAP, and you have to manage not just the alcohol-associated liver disease, but you have to manage the alcohol use disorder as well. So in places where you have the opportunity to consult addiction medicine, strongly recommend that. And also managing withdrawal can be kind of challenging in these folks. Another thing that's really important is looking for and ruling out infection. So looking for, even if they're not having symptoms, really looking for pneumonia, cellulitis. If they have ascites, do they have spontaneous bacterial peritonitis? Do they have a UTI? Kind of doing your real pan culture, diagnostic para, chest x-ray, and broad spectrum antibiotics only if they're indicated. And we'll talk about antibiotics in the context of treatment for ALCAP in a little bit. You're also going to have really a lot of vigilance and close monitoring for renal insufficiency, because folks who come in with acute ALCAP are at increased risk for renal insufficiency, and that's definitely a poor prognostic indicator. So these are the folks that you're going to give volume expansion with albumin. Additionally, as part of your evaluation, you want to make sure that you're ruling out other causes and not just kind of anchoring on, this looks like ALCAP. We got to make sure we're ruling everything else out. So, first things first, ultrasound with Dopplers, looking for biliary obstruction and vascular occlusion like portal vein thrombus or Budd-Chiari. If you haven't already learned about livertox.nih.gov, let me be the first one to tell you about how awesome this resource is. It's great to look for drug-induced liver injury, so you can just pop in supplements and medications that patients are taking to see if that can cause any liver injury. So that's a really important thing that we need to do. I use it every single day in clinic and most days when I'm on service. Also important to do a complete serologic evaluation, looking for viral hepatitis, autoimmune hepatitis, and also looking for ischemic hepatitis if they're coming in with shock, cocaine, GI bleeding, other things. And as I mentioned before, if their presentation is atypical, if their labs don't fit, if they're saying, I really don't use alcohol, or if you're thinking, maybe there's something else going on, those are the folks that you're going to consider doing a liver biopsy in, and you're going to look for kind of the features of alcohol-associated steatohepatitis. So once we've made the diagnosis of acute alcohol-associated hepatitis, really the next step is understanding prognosis, because prognosis is really tied to treatment and how we guide the next steps. So there are varying prognostic scores that we use to assess disease severity and identify those high-risk patients where we need to consider steroid treatment for. So severe ALCHEP, over time with improving care for liver disease, we're seeing better survival. Recent reports are suggesting a 90-day survival of 35 to 70% for severe ALCHEP, which is better than prior studies have reported. And then there's this other category of moderate ALCHEP, and there's less known about the natural history of this entity, but reports are saying like 1-year mortality of about 10 to 20%. There was one study that suggested a 3-fold higher survival at 1 year for people who have moderate ALCHEP compared to those who have severe ALCHEP. In addition to these prognostic scores that we're going to dig into very deeply, extrahepatic complications, particularly acute kidney injury and serious infections, really profoundly impact outcomes. And even the presence of SIRS criteria at admission are associated with a 3-fold increased risk of mortality and development of renal failure. In the long term, it's really abstinence from alcohol that's the main driver of outcome in people who are going to survive over 6 months from ALCHEP. So this is a busy slide, just kind of summarizing some of the prognostic models that we have for assessing ALCHEP. And we're going to go into a couple of these, the MADRS, MELD, and LEAL. So the MADRS discriminant function was derived from the results of early clinical trials comparing steroids to placebo and later modified to identify those patients with ALCHEP who have a high risk of short-term mortality. It's really this kind of historical index that helps us assess disease severity, characterize people as severe versus moderate, and decide who's eligible for steroid treatment. It was really the inclusion criteria for most ALCHEP clinical trials, and it's been extensively studied. The variables that it uses are total bilirubin and ProTime. ALCHEP is considered severe when the MADRS is 32 or higher. Again, identifies folks who have a high risk of short-term mortality, and it's considered the threshold for when to consider steroids. However, there are some limitations to this prognostic index, and we'll talk about MELD, which has been shown to be a better score. So the main limitations of MADRS is that it doesn't include the creatinine, which is now a widely recognized prognostic factor in ALCHEP. And also PT measurement varies between labs. If you've ever tried to calculate the MADRS, the question always comes up, well, which control time do I use? And so depending on if I calculate it or you calculate it, our numbers may be different depending on the control time. And that's going to really impact who gets steroids and who doesn't. You can also have false positives that end up leading to overuse of steroids. So that's kind of alluding to. So better score is the MELD, which many of you are familiar with, having rotated on LTU. If you have not yet, you will become very familiar with the MELD. It is considered, ALCHEP is considered severe when MELD is greater than 20. And a recent study found that MELD was superior to MADRS to predict short-term mortality in ALCHEP. So this was a cohort of over 2,500 patients with ALCHEP. They compared MADRS, MELD, and several other scores. And they showed, again, MELD is really the score that best predicts short-term mortality, and that MADRS was significantly less accurate than all of the other previously validated scores. When they looked at MELD compared to MELD sodium actually did not further improve the accuracy of MELD. It was really just MELD itself. Overall, MELD is favored over MADRS due to improved accuracy, worldwide use and organ allocation. We're using INR instead of the ProTime, as I mentioned, some of the issues with that in calculating MADRS, and that incorporates the creatinine. Some of you are hopefully familiar with the MELD 3.0, which now includes variables from the original MELD, total bilirubin and INR. Plus it includes patient sex, sodium, and albumin. Adults who are female receive sex priority points that helps address the sex disparity in transplant because women have historically been less likely than men to undergo transplants. And so that's why we're using the MELD 3.0. That's one of the reasons why we're using MELD 3.0 now. There was a retrospective registry study of patients who were admitted with severe ALCAP that looked at the performance of MELD 3.0. And they showed that MELD 3.0 actually did better than MELD sodium and MADRS, but was similar to MELD in terms of predicting 30-day and 90-day mortality. So again, MELD 3.0 not superior to MELD, but better than MELD sodium and better than MADRS. They did show, however, that MELD 3.0 was a better predictor of need for renal replacement therapy during admission compared to all of the other models. And as I've alluded to earlier, we have seen that people who have renal failure and those who need renal replacement therapy actually have worse survival, as you can see from this, this graph here, whereas people who had need for renal replacement therapy in red had significantly lower survival compared to those who did not need renal replacement therapy. So to kind of round out our prognostic models, we have to talk about the Lille model, which is a dynamic score that incorporates the change in bilirubin at either from day 0 to either day 4 or day 7 after starting steroids to assess the early treatment response and the utility of continuing steroids for 28 days. Classically, this score has been calculated at day 7, but day 7 of steroids, but more recent data has shown that calculating at day 4 is just as accurate as day 7 in predicting response to steroids, as well as short-term and kind of intermediate-term mortality, 28 and 90-day mortality. So if you're assessing the efficacy of steroids at an earlier time point, at day 4 as opposed to day 7, you can potentially avoid more prolonged futile use of steroids, which do come with risk, which we'll talk about in a minute. So how do you use this score? So you calculate the score and you get a value. And a cutoff value of 0.45 or greater indicates that the patient is not responding to steroids and they have an overall poor prognosis. That should lead you to stop steroids. If their score is less than 0.45, that indicates that they are responding to steroids. So you should plan to continue steroids for 28 days, followed by a taper. I'm including kind of an interesting model that combines both the the MELD, a static score, and the Lille, a dynamic score, to improve outcome prediction. So this is a joint effect model of MELD and Lille. And so each of these lines, hopefully you can see my arrow, is indicating survival. And so basically you calculate your Lille model, you calculate your MELD score, and you can kind of assess that this patient with a Lille of 0.45 and a MELD of 21 has about a 24% 6-month mortality rate. So that is helpful to kind of enhance our prediction of how people are going to do. So now that we know how to diagnose it, we know how to prognosticate and assess if people have severe or moderate ALCAP, we're going to jump into ALCAP treatment. So I'm going to go across the limited spectrum of treatment we have available for ALCAP. I won't address everything, but we'll go through kind of the heavy hitters. So there are things that have proven benefit, and that is alcohol abstinence. There are things that have likely benefit, and that's corticosteroids and nutrition. There are things that have potential benefit, and we'll talk about N-acetylcysteine or NAC. We won't spend any time on G-CSF because there's really not enough data to say that that's ready for prime time. And then there are things that have unlikely benefit. We'll just talk about pentoxifylline and empiric antibiotics and not talk about the rest of them. So we'll dive into alcohol abstinence because this is really the key, but it's also really, really hard to kind of achieve. So all patients who have alcohol-associated liver disease should be advised to abstain completely from all alcohol completely because continued use leads to really bad things like dying, variceal bleeding, encephalopathy, ascites, and liver cancer. We need to implement relapse prevention strategies early on. And unfortunately, we just don't get a lot of training on how to do that. And so we have to rely on our colleagues in addiction medicine, social work, and addiction counselors to help us really help our patients. The ideal is a multidisciplinary, multimodal, integrative care model that helps take care of the person's alcohol use disorder and alcohol-associated liver disease at the same time. So this, Zoe had mentioned that I started our HALT clinic, which is where patients see me and Ariel Klepper and our addiction counselor on the same day, and they're offered the opportunity to meet with our addiction medicine physician, Trevani DeFries, who many of you might know from the general. And working together, all three of us are taking care of both their AUD and their ALD kind of all at once. So the ideal is really to, let's see, refer to an addiction or an AUD treatment professional, though insurance can make this a little bit challenging. In our clinic, insurance is not an issue. I know at the general, folks are easily able to get into bridge clinics. So really referring people to AUD treatment professionals is really the key. But I'm also going to give you some tools that will hopefully help you feel empowered to start treating AUD as well. AUD treatment may include, a variety of different things, whether it's medications, combination psychotherapy, cognitive behavioral therapy, motivational interviewing, 12-step programs like AA, LifeRing. There aren't a lot of data to say that one modality is better than the other. It's really just getting people into care. Is there benefit to relapse prevention planning and AUD treatment? Yes, it seems obvious, but I'm going to show you the data. So in this retrospective cohort study of veterans with cirrhosis who had alcohol use disorder, any AUD, whether it was behavioral or pharmacologic, was associated with a significant reduction in incident hepatic decompensation. And that is shown in the striped bars as opposed to the black bars. So there was significant reduction in decompensation and long-term all-cause mortality. In another retrospective cohort of veterans with alcohol-associated cirrhosis and high-risk alcohol use disorder, medications for alcohol use disorder were underutilized, but when they were used, they showed significant improvement in survival after adjusting for confounders like severity of liver disease, age, and engagement in the healthcare system. Despite these benefits, getting treatment for AUD in people who have alcohol-associated liver disease is the exception, not the rule, and it's really time for change. And I'm hopeful that after this talk, or after you come and hang out with us on LTU and hang out with us on Halt Clinic, you feel really empowered to start treating people if you haven't already. So again, very busy slide, but this is a list of AUD pharmacotherapy. There's really a spectrum of options. I'm just highlighting the ones that we use the most. So naltrexone and acamprosate are FDA approved first line. I will highlight naltrexone in just one slide. But I think, what's great about naltrexone is that it's one pill once a day, and overall pretty well tolerated. Some people get some GI side effects, and so you can start with half dose for a couple days and then increase to full dose of 50 milligrams once a day. I've been using that more and more. Acamprosate, another great medication. Sorry, I should say that naltrexone has a number needed to treat to prevent any drinking of 20 and number needed to treat to prevent heavy drinking of 12, so pretty good. Acamprosate, sorry, number needed to treat to prevent any drinking is 12. This medication is great, and I've had a lot of success with patients taking this and reducing cravings. That said, it's 2 pills 3 times a day, which is quite a lot of pill burden. Some patients have said that it's easier for them to take 3 pills twice a day. So that's one option. The one thing about this is that you need to assess their renal function and dose adjust for renal function. Gabapentin is another great option. Great because people are often already on it for various different things, whether it's pain or peripheral neuropathy. Again, 2 pills 3 times a day and need to dose reduce for renal function. And, if you've used gabapentin, you've seen that people can get a little confused. And so maybe not ideal in folks who have hepatic encephalopathy. Just thinking about naltrexone, I know that this has often been a hot debate on the consult service, and can we use naltrexone in people who have liver disease? The answer is yes. Naltrexone is safe in people who have liver disease, including people who have compensated cirrhosis. There's a very low incidence of liver enzyme elevations, no clear evidence of hepatotoxicity. In terms of decompensated cirrhotics, more data is needed before we can kind of globally use this, but the available data that is out is encouraging. I have used this in some decompensated cirrhotics. If they say that this is the only thing that has ever worked for them, this is just something where you have kind of shared decision-making with the patient. We know that alcohol is hepatotoxic, and there's not clear evidence that naltrexone is, so I err on the side of using it if that's really the best medication for the patient. Alcohol biomarkers is another thing that we should just mention quickly. We use biomarkers to augment the detection of covert alcohol use and really try to find, identify those patients who return to alcohol use so that we can find them kind of early on and engage them in care early. It's really important before you start sending these tests to tell people, hey, I'm going to send this test. It's hopefully going to help, encourage you to tell me that you're drinking, or, that we can kind of maintain a therapeutic alliance by telling them that you're going to send this test to improve their disclosure. The last thing you want is for people to feel like they're going to be caught because you're using this test. There are a couple urine tests that we used to use, but now that PEth, or phosphatidylethanol, is widely available, we're really using this test almost exclusively. It is kind of like the A1C of alcohol. It can detect, it's a blood test that can detect alcohol use for about four weeks, particularly in kind of moderate to heavy users, and really has excellent test characteristics and very, very kind of low rate of false positives. Like, the only kind of thing that we can see that causes false positives is maybe if somebody's gotten a ton of blood transfusions, because the test itself is looking for something that incorporates into red blood cells. So switching gears to steroids, really our only medication that we have available for ALK-HEP outside of clinical trials. So you may be familiar with the STOPPA trial that was published in the New England Journal now almost a decade ago that looked at steroids versus pentoxifylline for ALK-HEP. This looked at over 1,100 patients with severe ALK-HEP in the UK. They showed no significant survival benefit with prednisolone versus placebo at 28 days, but in post hoc multivariable analysis, they did show that steroids had improved 28-day survival, but not at 90 days or 1 year. They showed that pentoxifylline did not improve survival. And something that's really important is that serious infections occurred in basically double the percent of people who were given steroids compared to those who did not get steroids. Another meta-analysis of over 2,000 patients compared steroids to pentoxifylline or a combination in severe ALK-HEP. And that showed that steroids significantly reduced 28-day mortality compared to placebo with a 36% risk reduction. And that is in the gray line is the steroids compared to our controls on pentoxifylline. They showed no significant differences, however, in 6-month mortality with any treatment or control. So again, really, these studies offer modest support for prednisolone, and the dose is 40 milligrams per day to improve 28-day mortality in severe ALK-HEP. And again, if patients show response based on the Lille model, you'll do 28 days, followed by, I generally do a 2-week taper. But, this data supports steroid use, but is there a way to decide, are there people who benefit more or less from steroids? Are there people who maybe don't need steroids or are not going to benefit and are going to get better on their own? So I think this is a really interesting study that was published a couple of years ago that looked at over 400 patients with severe ALK-HEP. And they looked to find, is there a group of people who have severe ALK-HEP that could potentially avoid steroids and have spontaneous improvement. So they found 3 trajectories of bilirubin over the first week of admission. Fast fallers in the green, where their bilirubin reduced by 0.8, their admission value at day 7. People who are static in the blue, where their bilirubin stayed the same, or rapid risers, bilirubin increased since admission. They found that fast fallers, who are the people in the green, who had a significant fall in their bili over the first 7 days of admission, had significantly better 90-day survival compared to all the other groups, and they actually showed no benefit with steroids. So this data potentially identifies a subgroup of patients with ALK-HEP who are going to recover spontaneously and can potentially avoid steroids, and then you can just reserve steroids for cases, without spontaneous recovery. So you could argue that this is saying, hey, maybe we don't need to rush to starting people on steroids on day 1 when they show up in the emergency room. Let's see kind of what trajectory they're on. And we'll talk about that in a second as well. Is there ever a group of patients that are too sick for steroids? Is there an ideal therapeutic window? Is there a ceiling beyond which steroids could be harmful? So this retrospective study that was international, multi-center, looked at people who had severe LCAP, and they showed that there was a max steroid benefit for people who had a MELD between 25 and 39. They showed that there was no steroid benefit in people who had a MELD greater than 51. It's important to know that, people who have very high MADRs or a very high MELD have very severe disease, and you need to be evaluating for occult infection or other contraindications to steroids. So what are those contraindications to steroids? Infection, acute kidney injury. Mainly acute kidney injury is considered a contraindication because it was excluded by many of the ALCAP trials. If their AKI improves, you can consider use. GI bleeding, also excluded from major trials. If somebody has a GI bleed, you're not going to want to start them on steroids. But after you get that controlled, whether it's from variceal bleed that you have now controlled with octreotide banding, then you can consider use. If they have multi-system organ failure, shock, if they have active TB, you're not going to start them on steroids because those are contraindications. This is just kind of a nice flow diagram of how you're going to do a systematic screening for infection. And then, whether you find an infection or not, you'll decide whether you can start steroids. And then again, assess the allele score. I think the moral of this story is be patient, rule out infection. In the STOPPA trial, the average time from presentation to starting steroids was 6 days. So again, take the time to look for infection. There is not a rush to get them started on it. So kind of leaving steroids and moving into nutrition, this is incredibly important and something that we probably don't pay enough attention to. Meta-analyses of nutritional support in ALCAP have shown improvements in encephalopathy, fewer infections. In an RCT that looked at people who had severe ALCAP who were treated with steroids, they basically showed that people who got lower caloric intake had more infections and higher mortality compared to those who had higher caloric intake. There are also commonly vitamin and mineral deficiencies, so those need to be addressed in supplements. Again, the moral of the story here is getting them adequate nutritional intake is the major goal. It doesn't matter if it's oral or a feeding tube. They just need to get the calories in and the protein. So I consult a dietitian on all of these patients and make sure that you get them their adequate protein and calorie needs. So what about NAC or N-acetylcysteine? Same thing that we use for Tylenol toxicity. So an RCT of IV NAC plus steroids compared to steroids alone showed that the combination improved 1 month mortality compared to steroids alone, but they didn't see a statistically significant benefit at 3 or 6 months. But you can see that, in the hashed blue line of prednisolone plus NAC compared to prednisolone alone, there's quite a separation there. And so I think the data is pretty convincing that adding NAC to prednisolone provides benefit. This is again supported in a meta-analysis of over 2,600 patients that again supported NAC providing survival benefit. So in general, adding IV NAC to prednisolone can improve short-term survival. We'll spend a second on pentoxifylline because long story short is the data isn't there that we should be using this medication anymore. So it was initially supported by an RCT that showed improved short-term survival compared to placebo. But subsequent studies have really failed to confirm any survival benefit, though there has been some data that showed reduced development of HRS with pentoxifylline. That said, STOPPA and high-quality meta-analyses have really failed to demonstrate any benefit of pentoxifylline, so the existing evidence does not support its use. And then our last treatment, or treatment that doesn't work, is empiric antibiotics. So we know that patients with severe ALCAP are at increased risk for bacterial and fungal infections. And those who develop infection on steroids have a higher rate of adverse outcomes, including HRS, worsening liver failure. There was a trial called Antibiocore that looked at amoxicillin clavulanate plus steroids versus prednisolone alone. And overall, that combination of antibiotics plus pred did not significantly improve 60-day survival versus prednisolone alone. The combination group, however, did have a lower rate of infection at 60-day follow-up. So, while prophylactic antibiotics don't improve outcomes, people who have severe ALCAP are at high risk for infections, and we need to be very vigilant for looking for infection and treating them promptly. So this is a guideline summary internationally of all of the stuff we have available to us for ALCAP. You can see that the guidelines are pretty consistent. They all kind of say the same thing. If it's severe, give them pred. plus minus NAC and nutrition. Calculate the Lille model. This guideline summary says at day 7, but again, it's okay to calculate it at day 4, and potentially you're going to save some folks a couple days of steroids. But what do you do if they're not responding? We really don't have a lot of other options. We're thinking about liver transplant and clinical trials if they're available to you. So now we're going to switch gears to the end of this talk and talk about liver transplant for alcohol-associated liver disease. As I've already highlighted earlier on, ALD is the leading indication for folks getting on the wait list and for getting transplanted, outpacing metabolic dysfunction-associated steatotic liver disease, or MASLD. You can see that in the pink lines here. You're just seeing this exponential rise in people who are added to the wait list and people who are being transplanted for alcohol-associated liver disease. When we look at outcomes, alcohol versus non-alcohol indications for liver transplant overall have had similar graft failure rates and death rates. But ALD did show an increased rate of late death and lower likelihood of retransplant. Based on kind of the database that the study was looking at, we don't understand kind of exactly what these outcomes are related to and why they had late death. You can make some assumptions, but we shouldn't be assuming that people have returned to drinking and things like that. But again, we don't have kind of the granular data to understand why people have a higher risk of late death and a lower likelihood of retransplant. So with this in mind, how do we kind of select appropriate candidates who have alcohol-associated liver disease for liver transplant? This is really a unique question because we have to think about their concomitant alcohol use disorder. AUD is a chronic brain disorder, does not get better with liver transplant, and has significant implications for post-transplant management and outcomes. We can't just say, okay, you got a transplant, everything's fine, go on your way. There are definitely varying rates of return to alcohol use. For people who are on the wait list, rates have been reported up to 30% return to use while waiting. Post-transplant, it's been reported up to 30% will have a slip or sustained alcohol use within follow-up of 2 years. You could imagine that it's really hard to capture this information because people who have had a transplant or who are on the wait list don't want to tell their providers that they have slipped or returned to alcohol use because of the implications on the waiting list. You could be removed, or you don't want to disappoint your provider who, got you to transplant or is working on getting you to transplant. So you can imagine that people are not going to be super excited about telling you if they've been drinking. So we know that return to harmful alcohol use is associated with rapid allograft fibrosis and death. This is an older study, but I think that it really highlights kind of the important stuff. So this is an assessment of survival, out to 10 years post-transplant. Overall, people who were abstinent had the best survival. People who resumed harmful drinking had the worst. People who slipped or had kind of an unknown amount of alcohol use, did better than people who resumed harmful drinking. But overall, people who resumed alcohol in general, compared to those abstainers, had significantly worse outcomes. So how can we predict the future and decide who are the kind of ideal candidates who are not going to return to alcohol use? When should you refer people to liver transplant for alcohol-associated liver disease? So kind of overall, the indications are the same as any other indication. If their MELD is 15 or higher, or they have poorly controlled portal hypertensive complications, if they have liver cancer or another MELD exception category. But what about their duration of abstinence? How does that factor into things? So until the last decade, the vast majority of transplant programs and insurers required 6 months of pre-transplant abstinence. And you might be wondering, where did that come from? So the 6-month rule came from a 1997 consensus conference. And the idea of it was that it had 2 goals. We're going to let the liver get better from the acute effects of hepatotoxicity of alcohol. Maybe people are going to get better and don't need a transplant. And it's going to let transplant programs evaluate someone's commitment to abstinence and implement some preventative strategies. And it soon enough became this surrogate for predicting future drinking in transplant candidates with ALD. That said, it also excluded potential candidates for transplant who had severe LCAP, who are medical non-responders and not eligible for medical therapy. So more recently, while abstinence shorter than less than 6 months has been associated with return to alcohol use after transplant, we know that return to use happens even in people who have been sober for more than 6 months. Even at UCSF, people who have been abstinent for more than 6 months, 20% return to use. Overall, we're seeing similar rates of return to use in people who have been transplanted for less than 6 months or more than 6 months of abstinence. You may be familiar with the landmark Franco-Belgian study that was published in the New England Journal back in 2011, in which they had no specified pre-transplant period of abstinence for people who had severe LCAP not responding to medical therapy. Their key inclusion criteria, it was very, very strict. Basically, this episode of severe LCAP had to be their first liver decompensating event. So they couldn't have known that they had liver disease and continued to drink. They had to have insight into their AUD. They had to commit to lifelong abstinence. They had to have insight into their AUD, close supportive family. Vast majority of patients were excluded because they had poor psychosocial profiles, and less than 2% of people were actually eligible for transplant. Of the people who got transplanted compared to those who did not, there was a clear survival benefit, and a small amount of patients returned to alcohol use after transplant. This was retrospectively reviewed in the US from one of our former fellows, Brian Lee, who's now at USC, who coordinated this Accelerate AH cohort in the US. They looked at 12 centers who were doing transplant for acute alcohol-associated hepatitis, and they showed really excellent 1 and 3 year outcomes, but they also showed that sustained alcohol use after liver transplant was the strongest predictor of post-transplant death. This is a study out of Hopkins that looked at people who got transplant in the standard, kind of more than 6 months versus early, less than 6 months. And you can see that patient and graft survival are similar for both groups. What about those patients that, maybe they're going to get better from their LCAP? That one of those reasons why we have the 6-month rule is seeing who could get better. So what happens to those patients that don't get a transplant? Do they get better? So this was a retrospective review of about 5 Accelerate AH sites that looked at patients who had a MELD of over 20, who were declined for transplant for various different reasons, and to look and see if they were going to recompensate. The dark bars represent those who recompensated, whereas the light bars represent those who remained decompensated. You can see that over time, recompensation rates increase, but the majority of people remain decompensated. Are there any potential predictors of who's going to recover? There was just a single center study that was published last year, 2 years ago, that showed that patients with a MELD greater than 25 and less than 90 days of abstinence, spontaneous recovery, which they defined as MELD less than 21 at 90 days after admission, happened in about 35% of patients who didn't get transplanted. But most of those patients continued to have NSAIDs complications, predominantly ascites and encephalopathy, and only 7% recovered to a compensated state with a MELD less than 15 and no ascites or encephalopathy. They showed that factors that were associated with recovery were lower, younger age, lower index INR, and lower peak MELD. Overall, showed lower survival in the spontaneous recovery group compared to those who got transplanted. And how does transplanting all these folks for ALD impact transplant for other diseases? There's really been this exponential rise in liver transplant for ALD. And there's this concern for an unintentional disadvantage for other indications for transplant, including HCC. So you can see the AH line here is the dark line, and then the kind of medium line is other ALD with a MELD greater than 30. You can see the percent of waitlist entrants with those indications is both going up, 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 and then the non-ALD MELD 30 plus is just kind of staying a little bit stagnant and maybe going down in the light bar. So there's this study that showed that AH candidates between 2014 and 2020 experienced improved waitlist survival and higher transplant rates compared to other candidates with a MELD greater than 30. So we really need kind of more study and, potentially allocation adjustments to ensure that we're equitably allocating organs. There was another study that was just published this year that again looked at, whether doing all these transplants for alcohol were going to end up causing other patients to get transplanted less often. And they did, in fact, show lower probabilities for other indications. So with all of this said, the guidelines have now kind of shifted to say, we should be considering highly selected candidates with ALD for transplant without a fixed period of abstinence. So how do we pick these candidates? We have to look at the big picture. We can't just think about the liver disease or the AUD. We have to think about their psychosocial factors as well. There are multiple different predictors, age, number of drinks, if they've had failed rehab in the past, and multiple different scores to help us try to understand kind of who are the candidates that are going to return to alcohol use after transplant. That said, there's no single tool that reliably predicts who's going to return to drinking. And every center is very different in terms of the resources they have, the candidate evaluation criteria. It's really very variable, and there's no standardized way across the country that is kind of monitored by UNOS or any other kind of governing boards. As you could imagine, I only have 1 minute left, so I'm going to just wrap this up. Post-transplant management of AUD is critical because, again, AUD is chronic and it's not going away with transplant. So we need to put in AUD relapse prevention plans early on, get them on MAUD or medications, get them engaged in multidisciplinary integrated plans, and monitor for return to alcohol use with interviewing the patients and their caregivers and monitoring with biomarkers like PEth. I have our early liver transplant protocol up here. I'm not going to go through that, but I have it there for you for reference. And I'm happy to chat with folks about it. But in summary, screen all your patients for alcohol use using validated tools at every encounter. I like to use Audit C. And then when we think about diagnosis and management of review the clinical criteria, make sure it really fits. Use MELD and LEAL to assess severity and guide treatment, and then pursue your infectious eval before you start steroids. There's no need to rush. And there's good data out there that says that we, should be transplanting people with no period of absence as long as they're very highly selected, that we do have much work to do in terms of organ allocation, making sure that it's equitable.